series. My name is Elsbeth McSorley, and I'm very excited to welcome all of you, and I'm happy to have so many of you joining us today. Today we're focusing on PainCAS, implementation and clinical workflow. Just to review the purpose of the PainEDU webinar series, this is an interactive way for us to communicate with the PainEDU community. It's a chance for us to share what we're developing. It gives us an opportunity to present pain-related topics that we hope are engaging and relevant. And it's also a chance for you to ask us questions and interact with us. Just to go over some webinar logistics and a little bit of housekeeping, participants can use their computer's microphone and speakers or telephone for audio. Please do not put your phone on hold, and all questions will be answered at the end of the presentation. You should see an image like this on your screen from GoToMeeting. Again, you can select telephone or mic and speakers to receive audio, and feel free to enter your questions in the chat box below, but just keep in mind we will be answering them at the end of the presentation. And just to cover the availability of today's presentation, all attendees will receive an email with a link to view the recording of the webinar online, and we'll also be sharing the presentation slides with everybody. I would now like to present one of our presenters today, Ms. Sadaf Charity. Ms. Charity has managed the PainCAS program's development over the past several years, from initial prototyping and feasibility studies to launching the completed program and conducting an efficacy study across multiple clinical settings. Ms. Charity has a background in managing healthcare and education grants and has worked on the development and testing of other web-based solutions in the areas of chronic pain and substance abuse. I would now like to present our second speaker, Dr. Kevin Zakharoff. Dr. Zakharoff is a licensed board-certified anesthesiologist with more than 25 years of clinical experience in anesthesiology and pain medicine. He is the Vice President of Medical Affairs at Inflection, an active faculty member at the State University of New York Stony Brook School of Medicine, a member of the Board of Directors of the American Society of Pain Educators, and the Medical Director of PainEDU and Pain Action. Dr. Zakharoff is a co-author of a number of our print publications, including the PainEDU Manual, a pocket guide to pain management.
Thank you, Elsbeth, for that introduction. And thank you to all our attendees for taking time to join us today. I would like to start off with a quick overview of what PainCAS is. PainCAS takes the pain and opioid risk assessments off the clipboard and into an online electronic format. The program was developed with NIH funding and launched in March of 2014. PainCAS offers an initial pain assessment, a follow-up pain assessment, and our validated opioid risk assessment tools, the screener and opioid assessment for patients with pain, the SOAP, or the COM, the current opioid misuse measure. Patients are able to access and complete PainCAS assessments from home or in the clinic, and once the assessment is completed, the program produces a patient report and a clinician report. The clinician report is then available to be downloaded out of PainCAS and attached to the patient's electronic chart. Today we will be talking about what we are hearing from practices that are using PainCAS with regard to their experiences of rolling out the program and using it daily. These are the PainCAS stakeholders or end users: administrative staff, clinicians, administrators, and patients. Each of these individuals have different needs, challenges, and value propositions and benefits that they will gain from PainCAS. As we move through today's presentation, we will reference which stakeholders certain information is most relevant to.
Thank you, Sadaf. And I think with respect to those stakeholders, we need to consider the fact that whether or not we're talking about patients, administrative staff, or clinicians, the whole idea of change versus staying in current logistics is something that we know from past implementations is a challenge. And this is despite the fact that everyone also knows that certainly in healthcare, there are always changes ahead, specifically with respect to the transition from a paper and pencil-based medical record to an electronic one. So the change being perceived as a negative is definitely a common denominator, but we also need to consider that the point in the distance holds change in the future. When we think about this in the context of assessing pain or other medical assessments, I think we could all think of how many times in the course of our lives we've been given the proverbial clipboard with the assessment to fill out. And as we move towards an electronic format, by design, it needs to move into an electronic format itself. The days of paper and pencil assessments need to go, and solutions that include the electronic completion of assessments need to exist. And this was clearly the key point of vision for us with respect to PainCAS. To minimize the impact of change, which we know can often be a barrier, we set out with the goal of developing PainCAS in a way to minimize the disruption to workflow, to minimize the change in logistics, and to make the transition from a paper to an electronic one as efficient and streamlined as possible.
With this transition from a paper-based assessment process to an electronic one, PainCAS can help a practice standardize how patients are assessed for pain and opioid risk. It does this by reducing clinician variability and setting up an assessment process that can be easily repeated throughout the day. This standardization fosters uniformity of care, continuity of care, and ultimately can lead to the improved quality of care. But there are barriers to the standardization. Individual preferences, whether clinical or administrative, as to what questions are asked of patients at certain times exist, as well as just the challenge of changing. If there are existing assessment processes or no assessment processes, this new standardized assessment process is something new and different that the clinic would adapt to.
Right, and I would just add to that the idea that in the pain environment today, one of the things that people are looking to do is figure out how can patients be treated and assessed in a more uniform way, and how can the treatments and the treatment options they receive be more unified and more transparent across the medical communities. And certainly this is one way to do it. If you consider the pain assessment to be the foundation upon which all treatment is then based, it has to make sense from a quality perspective that you need to standardize the assessment in order to achieve that goal.
And the switch from moving from a paper-based process to an online electronic process also has a number of additional benefits. First and foremost is improvement in documentation. So that transcribing of paper assessments into a form in the EMR or scanning paper documents goes away. And now there's a PDF that's available and just needs to be attached to the chart. Electronic assessments also offer the opportunity to access and analyze the data that's available from these assessments that are completed. And that data can be used for a variety of different reasons, including quality improvement, evaluating clinical processes, and research. We're hearing from sites that PainCAS is very easy for their clinic staff to use. They get used to it in a couple of days. They need minimal training, if any at all. And the processes that they're implementing daily just take a couple of minutes, if that. We're also seeing that with this opportunity of assessments being remote and patients being able to access assessments from an email or online from their home before they even come into their practice, opens up opportunities to make the clinic workflow more efficient. And add on top of that, removing the process of transcribing or scanning results enhances that efficiency. The barriers that are there for moving from a paper-based process to an online electronic one are, again, change, where you might be used to a certain process and the forms that patients are using, and now that's going to be changing to a new system and a new form, all online. Dealing with patients' level of literacy, whether it's just reading or comfort level with computers or tablets, is another challenge. And that then requires staff to be available to help patients. Some of those patients might have needed help with the paper assessments anyways, but then they still might need help with sitting down in front of a tablet to complete the assessment. But there is that opportunity that assessments can be done from home before the patient even arrives in the clinic. And that's where the connectivity or patient's access to email and internet can become a barrier in certain areas.
Yeah, and the only thing I would add to that, or a few things I would add to that, is that we have heard of so many different variations of the way the clinic settings are dealing with paper and pencil assessments. In some cases, patients complete them, then they're scanned into PDFs, and then they're attached to the electronic medical record. In some situations, when maybe the SOAP or the COM are administered to patients, somebody actually, a medical assistant or other person, is tasked with scoring the opioid risk assessment and then refilling it out in another form, which is then added to the electronic medical record. So we have tried to figure out how to bypass all of these steps. And we certainly understand that people are comfortable with their existing workflow, but we've also heard from many people that those scanned documents or documents that are in need of scanning could stack up. They could result in a backlog, and in some situations, unfortunately, never even make it into the medical record at all. Now, Sadaf mentioned this, and I just want to spend a moment talking about this because I think it's important, and this is the result of a study that I talk about all the time. We hear from different clinical settings, either because of the rural nature of their patient population or some other reasons, that they often consider the idea that the majority of their patients, or many of them, don't have access to the internet. We clearly looked at the point in the distance with PainCAS across its development as aiming towards the point where the majority of people do have access to the internet. And what we're looking at on this screen is a survey that was done by Pew Research back in January of 2014 that showed that 87% of adults in the United States do use the internet, which is up from 14% in 1995. And we expect that number to just continue to increase. Certainly, we see a number of healthcare systems developing patient portals where patients can have access to their medical records, they can do scheduling, and so on and so forth. So I think you would be hard-pressed to find that the point in the distance isn't in some way, shape, or form not only an electronic form, but also one that is web-based and allows for this connectivity that the patients will have over time as we move towards the future. Now, when we think about some of the other things we were aiming for with respect to PainCAS and some of the things that moved us along the path of its development, leading it to the marketplace, encouragement of dialogue and transparency is something that can't be ignored. I know that Sadaf mentioned literacy before, and we did develop the PainCAS assessments to a 5th to 8th grade reading level. I don't know many clinic settings that set out with their paper and pencil assessments and know what their reading level is or the literacy level is of those documents, but we took a lot of time and energy to devote to that. And that is from the patient perspective. From the healthcare provider perspective, what we were really looking to do for the healthcare provider is to present the pertinent positive information for the clinician in an at-a-glance fashion. So if it's a paper document that they're picking up in the holder as they're walking into the exam room, instead of leafing through in a new patient's chart 100 or so questions with 100 or so answers, the clinicians could have the ability to just look at the pain assessment, see what pertinent positive information was necessary to understand to facilitate dialogue with the patient, in an efficient way as possible. From a documentation perspective, which I'll talk about in a moment, all of the questions and all of the answers are there, but this was our intention with the ability to move the discussion right to why the patient's there, what needs to be discussed, and facilitate dialogue between the patient and the healthcare provider. In the same exact way, we developed reports for the patient to have so they could monitor their progress. They could get access to educational information that is credible from the perspective of the healthcare provider that they're seeing, and also allow the patient's wheels to start turning to then have them discuss things with their healthcare providers, such as treatment goals and expectations, which in my mind are some of the most important discussions that need to take place. There are a lot of benefits in that regard, but when we think about potential barriers, well, we have to go back to that whole change idea. Everybody is used to what they're doing, and they sort of like what they're doing, and there could be resistance to change. When dialogue is increased, then sometimes actions need to take place based on that dialogue, and that moves us away from the paternalistic approach to healthcare, which is something, as someone who teaches medical ethics, we want to do, but very often can take some more time and take some navigating. And then lastly, I would mention the idea of transparency is a double-edged sword. It could be a good thing, it could be a bad thing. For people who are just trying to move patients quickly through the process, transparency could lead to further discussion, and communication is definitely a key thing, but there might be some resistance to it initially. This is just an example of what the clinician report looks like. We've definitely covered this before in prior webinars, so I'm not going to spend a lot of time on it. But as you can see there on the left, there's the important information that identifies the patient and the specifics about them. And then on the right, you could see the pertinent positive information related to the pain complaint. And this is really what we were trying to do. I know Siddharth touched on this earlier, but it's worth mentioning that the integration of opioid risk assessments is another key point in terms of us trying to move the needle a little bit. For those of you who are familiar with the SOAP and the COM, they are really considered by many to be the gold standard opioid risk assessments for assessing risk of aberrant drug-related behaviors. For those of you who are not familiar with it, I highly encourage you to go to PainEDU.org and get some more information about them. You can look at the tools. We felt it was really important to treat these opioid risk assessments, since opioids so often come into the field of view in treatment of chronic pain. We felt it was important to just weave these into the assessment. In most clinical settings that are using paper and pencil assessments today, the SOAP and the COM are treated as additional assessments. And patient fatigue is definitely something we need to think about, but I think when patients are given a clipboard with an assessment that's either 4 or 5, 6 or 7 pages long and they hand it in, the last thing they want to do is be given yet another form to fill out, let alone the idea that somebody's got to sit down and, as I mentioned before, score it. They have to identify the risk stratification, and there's no ability in any of this story where paper is being used to track what's happening over time. And when we talked about the move from paper and pencil to electronic, a key piece of this is that the big question in pain management today, maybe more than ever before, is what treatments work, what treatments don't work. Do opioids work over the long haul? Do they not? Are they efficacious or not? A lot of this data doesn't exist because there's nothing providing the data for people to look at. A scanned paper document into a PDF is not data. Every assessment that is created through PainCAS and every question within that assessment is a data point, and that includes the questions in the SOAP and COM, and that includes the score and the risk stratification for the SOAP and COM as well. Now, with respect to the pushback from this, if existing policies and procedures don't exist in a clinic setting, then the idea of incorporating an opioid risk assessment into the assessment could be something that people would want to discuss and could find challenging. And we certainly realize that. So you do not have to choose to use the opioid risk assessments with the PainCAS if you don't want to, but we put it there as an option if you do. So you can basically weave it in and out as you like. You can use the SOAP and the COM as necessary for the appropriate patient populations. Some people perceive the additional information as something else that needs to be dealt with. Well, my answer to that would be, I would consider, as a pain expert, standard of care in 2015 to be, if you're prescribing an opioid for someone with a chronic pain condition, that there's some documentation in the electronic medical record that shows their risk from an opioid aberrant behavior perspective. And the additional information is necessary to have. I touched upon the patient fatigue issue, so I won't harper on that. And with respect to the opioid versus non-opioid therapy, if the patient's not a candidate for opioids, then you don't have to include the opioid risk assessment as part of the assessment process. I touched on this before, but I don't think that this can be overstated. Most of you out there who are in the clinician world know this, whether we're talking about malpractice or chart reviews or anything else, especially in the world of pain management. Documentation is what we always hear. If you don't write it down, then it didn't get done. And what we really looked to do with PainCAS, from a benefit perspective, was create a system that would make the documentation as simple as possible. And not only as simple as possible, but also increase the likelihood that the documentation would end up in the medical record. We published a paper on this subject, so I encourage you to look for it and seek it out. But we did do some studies where we looked at documentation pre and post PainCAS implementation, and documentation in the chart improved very, very dramatically. With respect to a workflow perspective, I think that somebody's job, you administrative staff members probably more than the clinician, somebody's job is to scan all this paperwork and get it attached to the electronic medical record. We looked at these key steps in the workflow with the intention of making these as streamlined and as efficient as possible. From the barrier perspective, in the assessment development particularly, and I think, Sadaf, we spent somewhere over 6 months developing the assessment, right?
Yes, we sure did.
We tried to look at the assessment and make it as comprehensive as we possibly could, while taking into account the time that it would take somebody to complete. And I was actually just talking with someone this morning who was in a pain clinic last week, where patients were filling out assessments on a clipboard. And I asked him, how long did he think it took the patient to fill it out? And he said somewhere around 20 minutes or so. I'm assuming that was an initial assessment and not a follow-up assessment. But what we really tried to do was we tried to make it as close to what it would take someone to fill this out in paper and pencil form as we possibly could. And we tried to make it from a workflow perspective as similar logistically as we possibly could as well. I talked about the internet access and the remote capability. I clearly see that as a benefit, whether we're talking about efficiency from a speed perspective or just patients, and Sadaf and I were just talking about this yesterday. A lot of times patients come to the clinical setting and they don't bring all the medications they're taking with them. And then there are those other patients who come in with a Ziploc bag filled with 10 or 15 vials. What we really were trying to do is we were trying to make this as convenient as we possibly could for the patient to have their medications with them, to do this at their own time frame, to offload it from the clinical setting so the assessment is actually there waiting for them when they come to the medical visit. And Obviously, in situations where patients either don't have access to the internet, don't have an email address, or for whatever reason didn't get to do it, it could be administered in a tablet form in the clinic setting if necessary. The beauty of it is that even if that's the route that's taken, as soon as the patient clicks submit on the tablet, the assessment exists, the report for both the patient and the clinician exists, and they can either be emailed or printed out for both parties. From the barrier perspective, connectivity will be an issue until that Pew Research shows us that 100% of people in the United States are connected to the internet. And with tablets comes tablet management. But one of the things that I'm seeing, certainly in my hospital, is that the use of tablets is on the increase, and I think we're going to see more and more of that. I probably see a day where when the doctor walks into an examination room that he or she might be holding a tablet, or the PA or nurse practitioner might be holding one, and the patient might be holding one of their own too. Now, Sadaf's going to just talk a little bit about the logistic perspective, so you administrative people would probably want to pay close attention if you could.
Thank you. So I'd like to switch gears just a little bit, like Kevin mentioned, and go over the PainCAS setup process. There are 4 very simple steps in setting up a PainCAS account for a practice. First is identifying the PainCAS account manager. This is the person who will actually go through the setup steps and set up the account, but they will also be managing the account over time. Once that account manager is identified, the next step is to set your clinic preferences, and these include things like what version of the soap do you want to administer to your patients? What question sets should new patients who are coming in for an initial visit receive versus existing patients who are coming in for a follow-up visit? Once those clinic preferences are set, then the next step is to add users. These include the staff members who will be sending PainCAS assessments or setting them up, the ones who will be downloading the PainCAS reports once the assessment is completed, as well as the clinicians whose patients will be going through the PainCAS assessments and who will be reviewing the PainCAS reports once they're done. And the last step is to set up the devices, tablets, laptops, or desktops maybe, in the practice that patients will use to complete assessments in the clinic when they forget to do them at home or they don't have access to do them at home. And then the daily process. Once the account is set up, the day-to-day process of using PainCAS involves 4 basic steps as well. Setting up or sending the assessment to the patient in advance so they have the opportunity to complete it from home, or completing it in the clinic. And then once the assessment is completed, PainCAS system generates reports, and so the last step of that process is really downloading those reports and attaching it to the patient's chart. Now this slide kind of takes a step back and looks at that whole cycle of setting up an assessment and ending with downloading the report to attach to the chart. And basically, what I would like to point out are the 3 main points when a staff member becomes involved with the PainCAS system. The first is when the assessment is assigned or set up or sent out to that patient. The next time is when the patient needs to complete the assessment in the clinic, and they might ask for help in logging into the assessment or going through the assessment. And the final step or point when a staff member interacts with PainCAS is when the report is available to be downloaded, and it needs to be downloaded and attached to the patient's chart. Clinicians very rarely, if ever, will log into PainCAS. For them, the report will hopefully be waiting for them in the chart when they're beginning their evaluation with their patient.
For you clinicians out there, we've definitely learned a lot of things along the course of PainCAS's journey. And what we're trying to show you here are the differences between a pain specialty clinic and a primary care setting. The way I sum up this slide is that when we queried pain specialists about what PainCAS could be and what they would be looking for it to do from a clinical perspective, they already had existing paper assessments in place in most cases. Every single patient that came to the pain specialty clinic received a pain assessment. There wasn't any thought as to why is this patient here today, What are they here for? Is it a pain-related complaint? It's a pain clinic. So obviously the answer to that's going to be yes. They already had in place an in-depth intake initial pain assessment. What they were really asking us to do was develop something that could improve their current processes and certainly streamline them and make them more efficient. From the primary care or non-pain specialty perspective, it was a total 180. In many cases, these clinical settings, despite the fact that they're where the majority of pain patients seek medical attention, didn't have an existing assessment. They didn't know what questions needed to be asked or didn't need to be asked. And they didn't have something that they could just present to the patient to fill out. Let alone the fact that if they were looking to give a pain assessment to someone, how do we determine which patients need to get the pain assessment versus not? Now, I know I talked before about the development of the PainCAS assessment and the fact that we were looking to make it timely and not fatigue the patient too much. In its initial version, it had a complete H&P in the assessment, and we took it out. We've heard from some clinic settings they would have loved if it had it, but we didn't want to create something that would take 30 to 40 minutes for patients to fill out. But we certainly realized that in a primary care setting, when patients are determined to have chronic pain, that they would be appropriate candidates for this. So we wanted to make it a little bit more of a turnkey kind of situation. And we also wanted to give the primary care setting the ability to choose just to use the opioid risk assessment tools if opioids were being prescribed, because they had their own questions. They didn't want to burden the patient with these kinds of things, et cetera, et cetera. And what we resoundingly heard from the primary care setting was, as opposed to the pain specialists, which wanted a process that was just more efficient, people in primary care wanted something with a little bit more meat that gave them a little bit more guidance about what questions to ask or what to make sure they documented in the electronic medical record.
And regardless of the type of setting that PainCAS is being used in, there are some considerations that we have for the implementation process. First is to really know your technical environment. What are your default browsers on your network? Do you have Wi-Fi in the clinic? Is there a patient portal that is used to communicate with patients? Next is communication about the change or the new process across all levels, from management of the clinic to the clinicians and staff, and as well as with patients, letting them know that there will be a new assessment process, that they might be able to complete these from home when they are able to. Looking at and understanding what is the current assessment process if there is one in place, and identifying the areas that will need to change or the steps in that process that will be different once PainCAS is implemented is important, as well as clearly defining who is going to be doing what in that new process. Who will be sending assessments, who will be downloading the reports, who will be there in the lobby to assist patients who need help with the assessment. And then when it comes to the rollout or the launch of the program, starting off with the controlled implementation, which basically means start small. Start with the clinicians or the administrative staff that seem most excited about this new tool. Capitalize on that motivation, and also start with patients who you think might be able to do this from home reliably. And then give that core initial group that's using the system opportunity to try different processes, try different workflows, figure out that one process that seems to work best. And then once you've landed on a process, roll it out across the practice. Every practice is different in their own way, and so this process of using PainCAS will be slightly different from practice to practice.
Yeah, and I couldn't agree more. I think we were actually just talking about this earlier today. This is sort of a checklist that's really important for everybody to know and understand. And at one of the early adopters of PainCAS clinic settings, which was a very large pain clinic, I remember a meeting where we asked them what was the typical flow, how did things work? And we found that there were so many steps involved, from the generation of a paper and pencil assessment till the time it actually ended up in the medical record. So this is almost a mandate, I would say, in terms of considerations that you need to have and understand when you're thinking about implementing a tool like PainCAS.
So now that PainCAS has been implemented, what can you expect? Patients will definitely need help, especially patients that are elderly or might not be comfortable with tablets or might have physical challenges with using the devices. Some patients will need help going through the assessment or at minimum logging into it, at least initially until they get used to this new tool and new process and then are accustomed to it. Patients may not complete the assessment prior to their visit, even if you had emailed it out to them. So when reminder calls go out to patients about an appointment, reminding them of the assessment, if they haven't had a chance to complete it, asking them to come early to give them time to complete it in the clinic. Patients might give you feedback that the assessment takes too long. And that's the point where you can remind them that this information is important for the provider to have, because then it enables them to get the most out of their visit. Like Kevin was mentioning earlier, instead of starting off a clinical visit with asking questions about how is your pain, what is it feeling like, things like that, the PainCAS report already gathers all of that information and provides it to the provider in an at-a-glance format. So instead of beginning the conversation with trying to understand where the patient is, they can begin the conversation with the critical things that they need to consider that the PainCAS report is already highlighted. And then there's that ongoing theme of resistance or reluctance or hesitation to change and new processes. And this can be best addressed by giving administrative staff and other people using the program opportunities to discuss what's working, what's not working, try something different, see if that works better. It really is giving, the important thing here is really giving the administrative staff an opportunity to try out different processes and land on a process that they feel that they own and that works best for them, for the practice, as well as for the patient. Now, in terms of what we're hearing from sites that are beginning to use PainCAS now, clinical benefits that we're seeing is that providers are really feeling the benefits of the at-a-glance format of the assessment report. And it allows them to get right at the heart of the matter and have a meaningful discussion with their patients rather than starting to explore and uncover what's going on. Timely access to the reports is also a big change. With the paper assessments, the assessment might be half completed or not completed at all, or it might not even be in the chart when the patient is in the appointment with their provider. And PainCAS improves all of that and makes that report available in the hands of the provider either at the beginning of the appointment or sometime during the visit. Providers are able to have more meaningful dialogues with patients, that Kevin mentioned, because of the report and the way it highlights those pertinent positives. And patients receive a report as well. And just the process of going through the assessment, we're seeing that patients are taking more time and answering the questions more thoughtfully, and they're more informed, and which leads them to become more engaged in the treatment. And then in terms of the administrative benefits, we are hearing that the intake or the initial assessment really improves the intake process, because that covers a brief medical history, a treatment history in terms of pain, as well as what medications the patients are on, just to give you a couple of those examples. The likelihood that the results of the assessment end up in the chart improves significantly when PainCAS is in place, and this manual scoring of SOAP or CALM and identifying what risk level a patient might be in, or the transcribing or scanning, all of that goes away with this automated electronic process. And therefore, paper assessments are minimized as well.
Now, clearly, the commercially available version of PainCAS is the result of, as you mentioned, Sadaf, 2 NIH studies and research grants. And what we took our stab at was a connected patient who gets a completed comprehensive assessment that pretty much captures what both pain experts and primary care clinicians would want patients to complete. What we've heard from the customers that are using PainCAS today is that it's extremely easy to use. And I think we did usability studies in the phase 1 grant, and we heard that from both patients and healthcare providers, that it was extremely easy to use, and that has been borne out in clinical practice. Everybody thinks it's pretty much easy to use and doesn't require a lot of training. It's very intuitive. We also found out very early on that patients, when they started completing the assessments at home, actually felt the clinical process began as soon as they started completing the PainCAS. Well, I don't know if I have met a patient that felt when they were handed a clipboard they had those kinds of feelings. And we certainly have also found out that patients put more thought into the assessments. It allows the patients to take their time to do it. And while Sadaf did mention the idea that patients may need assistance, being the son of an 86-year-old mother, when I go with her to office visits and she's given a clipboard to fill out, I'm the one who helps her fill it out. I think that we have certainly seen that patients put more thought into this, and that if somebody's helping someone complete this, then they can put more thought in it too. Lastly, we've also resoundingly heard from our customers that the fact that the reports are available right away is a critical piece of the puzzle, as opposed to lost in some pile of either to be scanned or to be attached. What we're hearing and what people are asking for in next versions, the interoperability of EMRs is something that always comes up. And what we did to neutralize that at this point in time was have the output of the PainCAS reports, both the patient and the healthcare provider, be a PDF format that could easily be attached to medical records. Someday, do we hope to be interoperable with the large electronic medical record systems out there? Absolutely. But if there are any of you out there, clinician or administrative, who use different electronic medical records, you'll know that there's very little interoperability between the different ones. So it's a point in the distance we hope for, and we've heard that's something that people want, but we're going to have to wait until there's some more standardization before we can achieve that. We definitely have heard that people want customization of question sets. They'd like to include certain questions that either we didn't include or exclude certain questions that we did. And that's something we can definitely see moving towards. And probably the way that we would do that is by creating modular question sets where people can select and deselect the sets of questions that they'd like to have with a standardized core. So from a workflow best practices perspective, I guess if we had to sum it up, here's what we would say if PainCAS is a consideration for you, and I think I speak for both Sadaf and I.
Yes.
There needs to be a champion that is identified, somebody in the clinic setting who takes ownership for it and who really feels that this is the thing that is going to help make a difference. We hear that pain patients are so challenging to deal with in a clinical setting, and there's so much variability and such a deficit in terms of a grasp of what works and what doesn't work. But it's going to take somebody who has that passion and who really sees this as a solution to that problem. I went through this with patient-controlled analgesia back in the day when that was something new on the horizon. And I was actually the champion for it in my hospital. It's a critical piece of the puzzle. The next thing we recommend from a best practice perspective is to make sure that you understand what your existing processes are and who is responsible for those things happening. You very well might find that from the time a patient fills out a paper and pencil assessment to the time it actually ends up in the electronic medical record, there could be 3 or 4 people who need to touch it to make it happen. And understanding those kinds of roles and responsibilities and processes could definitely help shed light on some of the changes that PainCAS achieves in terms of efficiency. And in the subcontext of this, there needs to be thought given about what might change with respect to PainCAS. I mean, the bin of documents to be scanned is going to go away, but then the queue of PDFs to be attached to electronic medical records is going to exist. And maybe roles and responsibilities are even going to change with the implementation of PainCAS. Critical pieces to pay attention to. And this is a question that we get asked a lot. You want to eliminate as many redundancies as possible. PainCAS is not intended to be given to patients in addition to a paper and pencil assessment. It's intended to be given to patients in lieu of a paper and pencil assessment, and we want to reduce patient burden to the degree that we can. We don't want to increase it. And I know Sadaf mentioned this, but I think it's a good final point. Start with a controlled implementation. You don't want to roll this out clinic-wide, because everybody might have different thoughts, different perspectives, different suggestions, and it might get a little bit too frenetic. It's probably best, if there is a champion, to have that champion be the beginning of the implementation, and then let it sort of organically spread from an implementation perspective. That's what we found has worked best. And at this point, I will leave it there and take it back to Elsbeth to see if we have any questions. Thanks.
Thank you so much, Ms. Charity and Dr. Zakharoff. I'm going to jump right into questions since I was collecting them during the presentation. They were coming through. So I'm going to start with, do you have the opportunity to select which version of soap you give to a patient?
Yes, yeah. So there are 3 versions of the soap that are available in the PainCAS system. The SOAP R, which is the 24-item soap, has the strongest specificity and validity. The SOAP 14 and the SOAP SF, which is the 5-item. So one of those first things that you'll be doing when you set up your PainCAS account is just that, identify which version you want to use with patients. So then after that, anytime an assessment is sent that includes the soap, that patient will have received that version that was identified. You could start off with the 5-item soap or the 24-item soap, and months down the line realize, or weeks down the line realize, it's too long or too short. At that point, you can go back in and change the preference to another version of the soap, and then it'll switch and patients can start completing that one. So it can be adjusted at any time, but it's a default that you can set.
And I'm actually aware of clinic settings that use the short version of the soap as sort of the preliminary screener. And if the patient scores on the side of high risk on the short version, they will then administer the 24-item revised version to the patient. So it does have that flexibility.
Excellent, thank you. I'm going to go to our next question. Are soap and calm useful when patients come to you already on opioids for a long time and you suspect aberrant behavior?
Yeah, so this is something that I have discussed with Doctors Butler and Budman, who actually are the fathers, if you will, of the SOAP tool. I used to, let's talk about the SOAP for a second. I used to refer to the SOAP as a screener to be administered to patients who are being considered for opioid therapy before the prescription is ever written. And Dr. Steve Butler actually corrected me, because in very many situations there are patients who present to a clinic setting who are already on chronic opioid therapy, and they're new patients to that clinic. And basically what he said to me was that the point is, yes, you can administer the soap to someone who's already on chronic opioid therapy. What it does is it provides an initial screening of that patient at that point in time. The current opioid misuse measure is a correlate to that, which is intended over time to reassess that risk, hopefully, every time the patient is given a refill for that opioid. But the soap is definitely a tool as a screener that can and should be administered to patients who are already on chronic opioid therapy if it's their first visit to your clinic.
Thank you. The next question, does PainCAS flag a situation when patients are likely abusing their medication or are taking a dangerous combination of medications that include opiates?
So I'll field this one, Sadaf.
Sure.
The answer is yes. I was just reading a journal this morning and an article about adherence. We included in the PainCAS assessment how patients take their medications and whether they take them as directed, et cetera, et cetera. PainCAS also asks patients every medication they're taking and the dosage of that medication and the frequency with which they take it. Now, that means it's not like electronic order entry, where if there's a combination of medications that is dangerous for the patient to be taking, that it's going to prevent that from happening. But what it will do is it will create an alert on the report page that will be considered a pertinent positive piece of information for the clinician. So it'll be right there front and center that the patient is taking multiple medications. I don't know if there's anything you would add.
Yeah, no, there's a section in the PainCAS report called Risk Factors. That is where the SOAP score is presented along with the patient's risk level or risk stratification. If there's a COM, if they're in follow-up, the current COM score would be presented right next to it with maybe an arrow showing that score, how that has changed since the previous assessment. But additional information in that risk factors section includes the patient's drinking, smoking habits, their other risk factors such as family's habits of alcohol abuse or drug abuse, the patient's habits in terms of drug use. All of that is presented on the risk factors page, and then Kevin also mentioned that medication information that's collected. So the report presents those different data elements, highlights the ones that cross a certain threshold, and highlight those for alerts for the providers to then look at as a whole and make a determination in terms of how they want to move forward.
Yeah, and actually one thing I would add to that is, despite the idea that we really want medicine to move towards a medical home model, very often care is fragmented and multiple medications, especially for chronic pain patients who are often on a number of different medications, are prescribed by a number of different healthcare providers. And PainCAS in its follow-up assessment does ask about new medications that have been prescribed or discontinued since the last visit. So it does capture information because it might very well go under the radar. If a patient is not there for their first visit, they come back for a second or third visit, and they've been prescribed a totally new medication by another healthcare provider that's not part of this clinic, and it might not be information that's captured, but PainCAS does capture it.
Thank you. Next question. Does PainCAS interface with EHRs and EMRs?
Yeah, so just to underscore, the integration or interface, if you will, of PainCAS today is by virtue of the ability to attach the report, which is in a PDF format, to the patient's electronic medical record, just like a laboratory result or a consult from another clinical setting. If somebody's interested in data analysis capabilities, we have all the data. And if somebody wants us to upload the data in raw form to them, we can do that. But that is our point of interface in 2015.
The only thing I'll add to that is that every account that is used there, every clinic that is setting up a PainCAS account receives a unique login link for their patients. That's the login link that gets set up or bookmarked on the tablets that patients might use in the clinic, but that kind of unique login link can also be made available to patients to access from the patient portal. So that's another way where if you've got that EMR system that includes a patient interface like the patient portal, patient emails don't necessarily have to be collected. You can direct patients to that portal and access the assessment there on the other side of beginning the assessment or accessing the assessment versus the documentation.
And this will be the last question so that we can wrap up in a timely manner. Is PainCAS available in Spanish or other languages?
Yeah, so the SOAP is available in other languages, and we certainly realize there's a need there. And in upcoming versions of PainCAS, the answer is going to be yes. But for now, PainCAS is available in English only.
Thank you, Dr. Zakharoff. Thank you, Ms. Charity. To all our attendees, we hope you enjoyed today's webinar. We would greatly appreciate your feedback, so please take a few minutes and answer the post-webinar survey. You'll be emailed later today. If you are interested in implementing PainCAS, there's a section in the survey where you can indicate your interest and provide your contact information, and one of our team members will be in touch with you shortly. If you had questions today that were not answered during the presentation, there is a section in the survey where you can submit your questions and we'll also get back to you. And we also invite you to visit the PainCAS website at PainCAS.com, and we'd love to hear from you. So please feel free to call us or email us. Our next webinar will take place in the fall, so stay tuned for details, and we'll look forward to having you join us then. Enjoy the rest of your day, and thank you so much for attending today's presentation.